Okay, thanks everybody for showing up. I'm really excited today. We're going to have a talk on the impact of COVID-19 pandemic on migrants and interrupted transit in Tijuana. Ietza Bojorquez is going to be giving the talk. She's in the Department of Population Studies and is the Associate Director for the International Core for our San Diego Center for AIDS Research, which I'm very excited about. Next slide. Dr. Bojorquez holds an MD and a PhD in epidemiology and a master's in science and public health. Her main research interest is on the social determinants of health in the areas of mental health, health-related practices, including diet, physical activity, and also migrant health. After graduating from medical school, she worked in health promotion in rural areas in Mexico. And from 2007 to 2010, she was the Deputy Director of Operations Research in Mexico's Ministry of Health. From 2010 on, she's been a professor researcher at the Department of Population Studies in El Colegio de la Frontera Norte, Mexico, where she is currently in charge of surveys of migration in Mexico's borders. She's a member of the board of the Atlantic Commission on Migration and Health Latin American Node, and she is currently working on a pilot study of a model to facilitate access to mental health care for migrants and a qualitative study of migrants' access to health care, among other projects. I really appreciate you coming on today to give your talk and for helping everything that you do along the border and with our CFAR. So take it away.
Great. So Ietza, I'll pause the share and you can share your screen, or I'll stop.
Okay, thank you.
Sure.
Okay, you can see my screen now, right?
Yeah. Perfect.
Okay, so, well, again, thank you for having me. I'm glad to be here today and also to see many of the co-investigators of this research that I'm going to present today in the meeting. So, well, I will start. And the title of my presentation is The Impact of the COVID-19 Pandemic on Migrants in Interrupted Transit. And I want to emphasize that because I'm going to explain a little bit more what I mean by interrupted transit. But I think that's the main like the framework I want to give to this presentation, and what I think is more interesting in one sense and more tragic in another sense. So the first thing I want to remind is that in Mexico we have had recent changes in migration flows. So from the point of view of Mexico, we were used to deal mainly with the huge phenomenon that is Mexico-US migration, back and forth, and returnees and people moving between the two countries, and also with a much lower or much smaller flow of migrants from Central America, mainly in transit through Mexico, which were considered like really people who stayed in Mexico for a few months or even weeks or days. So the main focus was not in that flow. But since the past maybe 10 years, we have had this diversification of the flow, especially of people of non-Mexican origin moving through Mexico, aiming to reach the United States. And some important aspects of this flow is that it includes a higher proportion of women, of children, of adolescents, and even of older adults, although it's not that frequent or it's not the main population. And also an increase in the number of families or the proportion of people who is traveling in family groups. We also have more diverse countries of origin going through Mexico, even if the majority is still from Central America, and especially from the three countries of Northern Central America, Honduras, El Salvador, and Guatemala. We are also seeing people from all over the world, basically. No? And we are also seeing more forcibly displaced persons. So without trying to be very specific with the administrative way of classifying people on the move, this means that we have more people who is actually in a condition of humanitarian need, to put it that way, because they are being forced to move or leave their places of origin because of violence, because of climate change events, such as hurricanes or drugs or things like that. And this means that the reasons they move and the conditions in which they are moving are different, as opposed to economic migrants who have a little bit more room for making decisions, preparing for the journey. In some cases, they have already networks through which they are moving. This is a more vulnerable population in that sense. And these humanitarian events, which are the movements of big numbers of persons, maybe in the thousands of persons, moving together in what has been termed caravans in some occasions, but it's basically big numbers of people moving together and staying in places such as campaments or campings or in conditions that are not, of course, are not ideal. And these movements are sources of sudden sources of numbers of people. So these movements require a different response from what was the case before. So that's a very important change. And the other thing is what I'm calling interrupted transit, which is a situation in which the person can't continue their journey for an indeterminate time because of different reasons. Yeah? So the main reason is because migration policies have been put in place in order to stop them from reaching, especially the United States, but also in Mexico. We have more tighter controls in the southern border than was the case before. In Central America, there have been a lot of changes in order to tighten the borders also. So we have more and more persons staying in cities, and now I'm getting to the region we are focusing on, which is the Mexico-US border region. We have, again, thousands or tens of thousands of persons staying in cities where they didn't want to be in the first place. It wasn't part of their plans to stay in those cities. So they are not prepared to be there. They are not, originally, they are not trying to look for employment or other sorts of integration there. They are in a limbo, waiting for the opportunity to continue their journey. So that creates a series of conditions that are important in many senses, but especially I'm going to talk obviously about health and mental health. And this interrupted transit implies an interruption of a migration project. So in personal terms, that means like a loss, grieving for the migration project. It has a lot of consequences in mental health, but also we have the economic and social difficulties. So in these circumstances, people usually are, they have low income or no income because mainly they are not working, they are living out of their savings, the ones they had for the journey, but if the journey gets prolonged in time, so it's going to be more difficult for people to keep going with the money they had originally. Also, they have to resort to other sources. They are also, many of them are living in crowded spaces, either in shelters, which may be the better places to be in these circumstances, but also in rented apartments or even in the streets, in conditions of crowding, lack of hygiene, etc. The uncertainty already mentioned. And also the thing of the situation of being in an unfamiliar setting. So most of these persons are in their border region for the first time in their lives, or they are not familiar with the region. They don't have social networks here. So they are very vulnerable in a number of senses. Now, what happened during the COVID-19 pandemic, which is still going on, but well, in the beginning, it was more clear this huge change that the pandemic brought forth. So the first thing was that the border closure, the closure of the border between Mexico and the United States added waiting time to this population. So they already had been in this interrupted migration situation because of policies such as the Migrant Protection Protocols, the MPPs, where they, instead of being able to make their asylum case in the United States, they were turned back to Mexico and made to wait here, and they had to wait for months usually. But then when the border closed because of the pandemic, well, the asylum processes got interrupted basically, and without a foreseeable date of continuation. So people just got trapped in a sense in the border. And some of them had to be there for months or even for years. We have people who have been living in a shelter for a year, for example. And this made these conditions I was describing before even more pressing, even more difficult for people. The other thing, and this was very important in Tijuana particularly, and for other cities on the border, which are major recipient cities for migrants, it was that the general hospitals closed or were almost closed because they were transformed into COVID hospitals. So they were accepting mainly COVID patients, especially during the first year or the first months. And the general hospitals are the main place where migrants in this situation get care in Mexico, especially, I mean, care for more severe conditions. For day-to-day ambulatory care, they usually resort to the services that are provided by NGOs, sometimes in the shelters themselves, or they pay for low-cost medical attention in the pharmacies, in the doctors who work within pharmacies in Mexico. But for major things, and major even including childbirth or accidents or things like that, they usually resort to the general hospitals, which are operated by the Ministry of Health, the state level ministries of health, and are in the theory they are free of charge, free of any charge, any cost, and also are migrants are in Mexico are entitled to access those hospitals regardless of their migration status. So it doesn't matter if they are regular, irregular, or whatever, they have the right to go to those hospitals. So the closing of the general hospital was a major problem, a major barrier for seeking care in the Mexican side of the border. The other two things was that, as I was saying, many of the services, the healthcare services the migrants receive are provided by NGOs or volunteers, and volunteers had to shelter in place or be in lockdown, and NGOs had less resources, economic and human resources to care for migrants. So all of this resulted in the perfect storm of health risk and lack of access to healthcare. And it had impacts I'm going to talk about two types of impacts. One of them is the SARS-CoV-2 infection and COVID-19, and the other one is about mental health. So both of the subjects I'm going to talk about are based on the research we did in this project, which was called Prevalence and Correlates of Latent TB Infection, HIV and SARS-CoV-2 infection among Tijuana migrants. And these are the names of the co-investigators for this project. It was a joint effort by the University of California in San Diego, in San Francisco, El Colegio de la Frontera Norte, and it also have funding by the American Academy of Arts and Sciences, and of course of UCSD-CFAR. So in this project, the main objective was to determine the prevalence of SARS-CoV-2 antibodies, but we included a number of other measurements, both biological and in a questionnaire and questions. So it was a cross-sectional survey. It was a non-probability survey in shelters and out of shelters, but I'm going to speak mainly about what the data we have from shelters. And the sample out of shelters was recruited with the help of the La Frontera staff, which is a project that Dr. Strati has also going on in Tijuana. And the fieldwork was conducted in November, December 2020 and February, April 2021. So it was not right at the beginning of the pandemic, but still pretty early on. And one important thing was that COVID-19 vaccination was not available at that time in Mexico, or was maybe at the end, it was beginning to be available for some populations, but not necessarily for the general population of which migrants will be part of. We did a SARS-CoV-2 antibody testing and nasal swabs for SARS-CoV-2, and also HIV tests and latent TB tests, but I'm going to speak more about, or just about SARS-CoV-2. And in the questionnaire, we have had a number of things related with migration and the consequences of the pandemic and of migration. Now, we were trying to target the more vulnerable migrants in these circumstances, so the more vulnerable migrants in Tijuana. And in order to do that, we developed this inclusion criteria. First, we wanted to include people either born in a Latin American or Caribbean country other than Mexico, or born in a Mexican state other than Baja California. So they were really migrants in that sense, not internal or local migrants. And for Mexicans, we had the additional criteria of having been being in Tijuana because they had been deported from the US, returned from the US, or internally displaced from another state in Mexico. So the idea was to try to focus on a humanitarian population. And we also had this criteria of being less than 5 years or less in Tijuana for those who were not Mexican, and 1 year or less in Tijuana for those that were Mexican, in order to try to capture people who were more vulnerable in the sense that they probably hadn't had the time to integrate in the city. We only worked with adults, 18 years old or more, and we had the questionnaire in Spanish, English, and French. Most of them responded in Spanish. So these are general characteristics of the sample. Slightly over half were female. 70.9% had children or minors, actually, minors traveling with them who depended on them. 78% of them were asylum seekers in the US, in the sense that they aimed to present their case for asylum or had already done so. And about a quarter of them were born in Mexico, and the rest were mainly from the 3 countries in Central America I mentioned before, mainly especially from Honduras. The mean age was 33 years. Most of them had a low educational level, less than high school. And half of them had already been in some sort of migrant detention, either in Mexico or in the United States. Most of them had access to water for hand washing, and also to soap, to masks, and all the other sorts of personal protection equipment and wash. And that was because this is, as I was telling you, I'm presenting the results for the sample who was recruited from shelters in Mexico. So for those of you who don't know, in the northern border of Mexico, there is a number of organizations providing shelter and shelter, food, and other services to migrants. And they have different sorts of services, and they have different sorts of capacities, but especially most of them have the basics like water for hand washing. So these were, in that sense, good conditions for migrants. Although, of course, there is a lot of crowding, a lot of other risk conditions. Now, about comorbidities and the history of COVID-19 about migrants and the results, the main results of our student, of our EPICO study. Comorbidities were relatively rare among this population, and it has to be with 2 things. It has to do with 2 things. First of all, this is a young population, relatively young population, as I showed you in the previous slide. And second, the comorbidities in the left the question was about previous diagnosis or medical diagnosis of these conditions. So access to healthcare or low access to healthcare also could have to do with the low prevalences we saw. So it was only 4% for diabetes, 8% for hypertension, 7% for chronic obstructive pulmonary disease, 2% for cardiovascular disease, and 5% for obesity. And that explains probably why there were relatively few complications or cases which had to be hospitalized with COVID. And some of them even didn't know if they had COVID before. 13% say that they thought they already had COVID COVID-19, and 11% of the total had previously tested positive. So most of those who said, I already had COVID, it was because they had symptoms, they had been tested, and they were positive. But on the other hand, once we had the results of the antibodies test, over half, 53%, were positive for antibodies. So this means that about, well, more than half of those who had already had COVID had symptoms or had been diagnosed with the disease. So probably this was because they have mild symptoms or no symptoms at all, but still they were probably capable of transmitting COVID. And in the conditions they had been traveling, in the conditions of the shelters, transmission was made easier. So there probably were many outbreaks that were undetected in the shelters and in other places, for example, migration detention spaces in Mexico and the US. And well, that's probably the most important result in this of this research. We only had 1.5% positive nasal swabs, so the incidence and at the moment we were doing the research was relatively low, but as you can see, the prevalence of antibody positivity was high. And as a comparison, to compare with some surveys that were done at more or less the same time, a national study, which is the Ensanud COVID, which was done in 2020, and it began about November, about the same time as us, but they ended up that in, I think it's still in 2020, but it's almost at the same time, and they found 25% seroprevalence in the general population in Mexico. So we saw double what the Ensanud COVID was seeing in terms of seroprevalence. In February 2021, we did a survey. Also, some of you were part of this research. We did a survey in the three main cities in Baja California. So it was in Tijuana, Ensenada, and Mexicali. And we found that 21% seroprevalence. So it's very similar to that of the general population in Mexico. And again, it's much lower than the one we saw in the migrant sample in the shelters. And also at about the same time, in December 2020, the Mexican Institute of Social Security, which is one of the main providers of healthcare in Mexico, did a national survey also of people going to the healthcare facility. So this is a different kind of sample. The other two are household surveys, but the IMSS facilities survey was done in healthcare facilities, and they found a prevalence of 33.5% for Mexico and 40.7% in the northern region, which included Baja California. So in any case, we found a much higher seroprevalence of anti-SARS-CoV-2 antibodies in migrants as compared with the general population in Mexico, which is an indicator of a health disparity or health inequity, if you want, indicating that migrants were especially at risk of contracting the infection during the pandemic, also not necessarily of getting ill with it, because, as I said, probably they were younger, and so their symptoms were milder. The factors we found that were associated with SARS-CoV-2 seropositivity were, well, in the adjusted odds ratio, it was mainly, I mean, having used a public transportation while in Tijuana would be a risk factor. So never or rarely using public transport was a protecting factor, and time in Tijuana. We believe that time in Tijuana might be a risk factor because it means people had been more time at the shelters, but we can't be sure of that because we didn't have a question that allowed us to check how long they had been specifically in a shelter. And public transport, of course, was a risk factor. So we think that the reason why migrants had a higher risk than the rest of the population of contracting the infection was probably that they were more exposed because they were moving first within Mexico, but also through Central America or other countries, and also into the United States and back. They were constantly being exposed to close proximity to lots of different people. So the potential of transmission was very high. Well, this is an analysis we did with some other researchers using the public data set of the health ministry in Mexico from January the 1st to May the 30th in 2020. So this was very early in the beginning of the pandemic. And we were trying to focus again in migrants in transit and asylum seekers. So we restricted the analysis to a comparison between people in the data set who were Mexican, of Mexican origin or born in Mexico, and people who were born in the 3 countries of Central America and were detected in the states at the Mexican northern border. So that was an attempt to try to capture this same population as I was showing before, but not necessarily those living in shelters, but those detected by the health ministry. And what I want to show here is, again, the difference between the migrants and non-migrants in that data set, and how migrants were at lower risk of hospitalization and death in comparison with non-migrants. So about half the risk of hospitalization. I mean, given that they were suspect cases of COVID-19, so they had already been detected by the health system as suspect cases. And they had much lower prevalence of risk factors for complications. So again, the general picture is migrants were more likely to get the infection, but less likely to get ill and therefore to be detected by the system, probably because in Mexico, tests for COVID were done just for suspect cases. So, and especially for those hospitalized. So it was a sentinel system that was, I mean, it was detecting a special or just a subset of the population of cases. Okay, so that was about COVID. Now about common mental disorders, what happened or what information we have here? Well, first I want to show you this. This comes from the EPIC study I was telling you at the beginning. So this is the population of migrants staying in shelters with the inclusion criteria I showed you before. And this is the score they had in the CSD-7, which is a screening instrument for depression. And one interesting thing is, first, the difference between males. Sorry, I didn't translate that one. We have males in the left and women in the right. The prevalence of scores over the cutoff was 37 for males and 53% for females, which is a common finding. Usually women score higher in this instrument. But I also want to highlight the difference in the distribution of the scores. So whilst males had the distribution that is usually seen in general population, so a lot of them had zero symptoms of depression. And then there are lower numbers that had higher scores in the instrument, which is still 37% is a lot, but the distribution is the kind of distribution that we usually see in general populations. At the same time, for females, the majority of them had scores that were over 0. So in these types of screening questionnaires, 0 is the expected, I mean, the expected result, because people is going to say, no, I haven't been feeling sad, I haven't been crying, I haven't been, I don't know, I haven't had insomnia, etc., etc. So when you see that most of these women had at least one or maybe more symptoms very frequently, this means a very important thing, which is that these women are really exposed to factors that are putting them at a lot of risk of mental health issues. And it's relatively similar in this other screener, which is for anxiety symptoms, the GAD-2. Again, we see a lot of persons over the cutoff. That's one thing, but also we see how women tended to score higher than 0, which means most of them were showing symptoms of anxiety in this case. If we compare this with results in other surveys that can be used for comparison, especially this survey, the ENCOVID 2020, which employed the same instruments as we did. So we had a prevalence of depressive symptoms in the shelters, general. I mean, we have the male and females together, of almost 50% for depressive symptoms, while ENCOVID, which was a survey, a national survey of the general population in Mexico, this was conducted by telephone, had about 20%. For the anxiety symptoms, ENCOVID found a higher prevalence, but this is within their, our result in the shelters is within their confidence interval, so it's not statistically different. And in comparison, the National Survey of Health in 2018 had found, using the same instrument for depression, a prevalence of about 16%. So also for depressive symptoms and anxiety symptoms, migrants seem to be especially at risk population, especially for depressive symptoms. So for the paper we published with these results, we combined the two instruments and the two conditions, anxiety and depression, in a single measure of common mental disorders. So it was it was an indicator of one, having the value of 1 for those who had either depressive symptoms or anxiety symptoms over the cutoff of these instruments. And we tried to find which variables were associated with having these common mental disorders in the sample of migrants staying in shelters in Tijuana in 2020, 2021. And we were especially interested in seeing if their migration condition, but I don't mean by this the administrative or legal condition, but we were trying to catch the impact of this situation of interrupted transit. So we had a question asking migrants why they were in Tijuana. And we used that question to classify them. So we said people who is in wait or waiting will be the ones who say they want to cross to the US, but haven't been able to do so yet. So they aim to cross, but they haven't been able to do it. For this analysis, we classify it as interrupted transit, especially those who had already been in the United States, but had been turned back. So they have like bounce back from the US. And our hypothesis was that this will be the most damaging condition for mental health, because those in wait still had some level of hope that they are going to be able to succeed in their migration project and their intended destination of their migration project, which is usually the United States in this context. But those in interrupted transit already have seen their migration project frustrated. And we had a third group, which we classified as not in transit. And these were the ones who say they wanted to stay in Tijuana. This was a very small group, so the lack of significance, of a statistical significance, might be due to the size of this subsample. So what we saw was that after controlling for a number of other variables, those who were in interrupted transit as defined for this analysis were the ones who were more likely to have either depression, anxiety, or both sorts of symptoms. So our hypothesis seems to be correct in the sense that seeing the migration project frustrated is a condition that is especially bad for mental health. We also saw that in the unadjusted odds ratio, having worked in the past week was a protective factor. Having been more time or longer in Tijuana was a protective factor, and this was still protective, although with a p-value of 0.08, after adjusting for other variables. And the experience of violence in Mexico was very significant in terms of the p-value, very significant risk factor for common mental disorders, and gender. Female gender also was a risk factor for common mental disorders. Risk factor was factor associated with higher odds of common mental disorders. So from these results, I want to again to highlight three things. First, being in this condition of interrupted transit or frustrated migration project was a factor associated with higher odds of common mental disorders. So this is a population that will need, even while the whole population of migrants in the shelters could be thought of as a population that requires mental health services, mental health care, or psychosocial probably healthcare or psychosocial care. Those who are in this condition of interrupted transit are especially at need of these types of services. And this is a result that coincides with what has been observed in Europe, the United States, and other refugee recipient countries, where persons who are waiting for example, for their asylum claim to be processed and granted, are especially at risk of mental health issues as compared with those who have seen their asylum claim already granted, so they are already refugees. And also people who is staying in these liminal places, in between places, such as people residing in migrant or refugee camps in the islands of Greece or Turkey, or some who aim to arrive in Europe but are Afghan, for example, Afghan refugees who are staying in Jordan while they want to continue on and get to Europe at the end. So this condition of being like interrupted in their migration projects, it's being more and more shown to be a very risky condition for mental health problems, especially common mental health problems, not disorders necessarily. The second thing I want to emphasize is that time in Tijuana was a risk factor for COVID, but was a protective factor for mental health. So probably this has to do with integration, with changing expectations, etc. And I think in the Mexican side of the border, we still have a lot of work to do on doing a better job of integrating migrants, and also of assessing or researching how integration can be a good thing for health in general. No? The third thing is that the experience of violence, which actually was quite common among this sample, is associated with a worse mental health condition. So again, the risk factors that, or the risks migrants face while in transit through Mexico are, well, very well known, and they have a heavy impact in the experiences in their mental health and other health aspects as well. And during the COVID pandemic, this was probably made worse by the fact that moving around was even more difficult. So economic resources were probably lower or less than in other moments. So we don't have the information in this data set to make a deep, in-depth analysis of what was associated with these experiences. But in general, we can see that they were an important factor for common mental disorders. So to conclude, first of all, migrants were disproportionately affected by the COVID-19 pandemic in Mexico. And I think it is very important to have data to show that, because even if this sounds very logical and intuitive, there are very few data sets that can really tell us what happened during the pandemic with migrants in Mexico. For example, the COVID, the official COVID data set doesn't have really a variable identifying migrants, or it has it, but it's missing, or it has a missing value in more than 90% of the cases. So it's important to have this research trying to make it visible how migrants were affected by the pandemic, and they were affected in different senses. So socially was one of them. I didn't show you the results here, but we also have data on how they were affected in terms of employment, food insecurity, experiences of violence, etc. But also they were affected psychologically and in terms of the infection, even if they had less complications, probably because they had less risk factors. And as I said before, there were probably outbreaks and cases of COVID-19 that went undetected because they were mild, and also because of limitations in access to healthcare. So that's why they weren't detected by the system. And I think this is important because one of the issues, the very important issues, I think, at the border region, is that we, on the one hand, we want to be a unified region. We know we are a community. We know there are a lot of exchange in many senses between both sides of the border. And at the same time, the COVID pandemic shows how easily that communication and that being part of a community can be broken by an infectious disease and a situation of health risk. And even while research has shown that border closures were not very effective in interrupting the transmission of the pandemic, especially land border closures, still, that's not to say that we want to do nothing about it. I mean, there is a potential for transmission, so there are measures that need to be taken. And as we can see in this mobile or people that intend to be mobile population, there is actually a high risk of transmission of infectious diseases, in this case of COVID-19. And it might be undetected, and we need to have systems in place to detect these issues and to try to prevent disease within the same migrant community and the same migrant population, and also from this community to the general community, and from the general community to migrants. We are not sure really where people is getting infected, and probably it's not that important to point fingers to where did you catch the disease. What I think is important is to be able to detect and respond to risks of transmission. And again, I want to emphasize that it is probably the situation of interrupted migration which made this population more likely to get infected, which in turn made them more likely to transmit the infection. So I think I will stop there and see if there are any questions or comments. Nirma has a question.
Yes.
No, Dr. Bojorquez, I don't have a question. I say thank you so much for the presentation. It came in a little bit late, but thank you so much for this data. I think, especially now, especially what you mentioned about the border restrictions and the effect on migration, having concrete data to inform policies is critically important. So thank you very much.
Thank you, Nirma.
Tatiana, did you have a question?
Yes, hi. Thanks so much for the presentation. It was extremely informative. I have two questions. One, regarding to the last point that you made, that interrupted transit was a risk factor, while the number of months in Tijuana was a protective factor for mental health. But I assume that these two are highly correlated because people who stay longer are those that are in the interrupted transit, but they seem to have a different effect on mental health. I wonder if you thought about why this might be. And another question regarding the very high seropositivity in migrants. Have you had a chance to explore whether there were any changes, any differences between different shelters that were correlated with higher, lower seropositivity of people who are staying there, and if there are any differences in how these shelters are run or set up with regards to that?
Wow, that's a great question, Tatiana. Thank you. That's our next paper. Let's write a paper on that. No, okay. First of all, about interrupted transit and mental health. I'm being a little. Yeah, I think that I was a little confusing, maybe, because I mean I'm using the term interrupted transit for the general condition or of being trapped at the border, unable to move forward to the United States. But for the mental health analysis, we had a different, more restrictive definition of interrupted transit, which was those who had been turned back from the United States. So people who hadn't yet crossed into the United States weren't classified as interrupted transit in that analysis, in that specific analysis. And they could also have long durations in Tijuana in this sample, especially at this time, because this was in the first year of the pandemic, when the border was really, really close, really tight. So some of those who had been arriving in Tijuana in order to cross into the United States during the past few months were trapped by the pandemic in Tijuana. So I think that's the reason why in this sample time in Tijuana was protected, but at the same time interrupted transit was it's not that correlated in that sense, because I'm using a slightly different definition of interrupted transit. And I think that it is important to continue deepening our understanding of what it means to be in interrupted transit. I think that's an interesting conceptual issue. And about the difference between the shelters, I'm not sure we have a big enough sample of all shelters. And also we will need to get more data about the shelters themselves, because we had questions about wash and the availability of wash for people in the place they live at the moment of the survey. So that gives us an indicator of how the shelter was. But for example, we could ask or see if the shelters were separating people in the dormitories at that time, or things like that, and maybe try to correlate that to positivity. The other thing is that the seroprevalence could have to do more with the conditions during the transit. So we will need to try to see who had been in the shelter for a long time or not. But I think it's a very, very, very interesting thing, a very important thing. And yeah, thank you for asking.
Davey, I think you had something you wanted to say?
Just a quick question. This was absolutely lovely. So do you have if you could pick one or two main recommendations for policy and that you think would help, what would those be?
Wow. For migration policy or for health?
Yeah, either one of those pertaining to this COVID issue here.
Okay. One is that I think that health policies intending to contain the pandemic had consequences on migrants, negative consequences on migrants that were probably not foreseen or not given enough attention. So I think there's a need for migration policies and health-related policies to be more integrated. And that means that the the agencies responsible for those types of policies need to interact more closely than has been the case. And that's all over the world, no? In order to protect the right to health of people, regardless of their migration situation. So that's one. And the other thing I think is very important is that in the border region, we need to keep working, because I know there are a lot of initiatives in place already. We need to keep working in having better communication and better decision making in terms of what is required for the region, so that when we have situations such as surges of migrant populations, increases in the numbers of migrants moving across the region, we had the public health response that is required in many senses. And I still think it's important to always preserve the right to health of people, regardless of their migration conditions. So we need to take care of their health, but also we need to do the epi-surveillance and the public health measures that are required in a coordinated manner. And I'm saying this because when you return people from one side of the border to the other, and that side, I mean the Mexican side in this case, doesn't have the capacities to receive those people in good conditions, that creates the potential for a lot of public health problems.
That's great. Thank you. Super good for us all to think about as we go through this process.
So I think we have finished.
I think we lost. Basically, there was a slide going to be showing, it was going to show who was next on our list. Let me see if I can get it. Oh, wait, he's back. Okay. I don't think we can hear him, but I can go through it. So here's our next STEM seminar with Nicole Stadnick and Borsika Raving, Bill Oswald, Paul Watson, and then we're going to be talking about meaningful engagement of diverse partners to address COVID-19 testing and vaccination uptake for underserved communities, strategies and lessons learned. It's going to be at September 22nd, so next month, 2 o'clock to 3 o'clock. It'll be a Zoom webinar, so hope everybody can make it. And I thank everybody for making it today. So hopefully everybody has a good week.
Thanks for reading that, Davey. Sorry, I dropped off. Better to drop off at the end.
All good. Okay, thanks everybody. Anything else you want to say?
Just if anyone came in late, or we'll post this up on the UC San Diego Prepare Institute YouTube channel. I put that in the chat, and also please check out more about Prepare at prepare.ucsd.edu. And thank you all very much for coming. We really appreciate it.
Good commercial, Steele. All right, thanks everyone.